Jay, we can go live now. Thank you. Thank you. So, a very good afternoon to one and all. On behalf of Biocon Biologics, I would like to extend a very warm welcome to all our participants today. And today being a very important day, as we are having a very renowned and eminent speaker and a practitioner in the field of dermatology, Professor Dr. Koushik Lahiri, sir. And today, though we are all connected virtually, these scientific platforms have definitely provided us a very great opportunity to interact with such great specialists and also learn from their experiences. And with that short note, let me take it's my privilege and honor to welcome Dr. Koushik Lahiri, sir. And sir is a professor and senior consultant dermatologist of Apollo Gleneagles Hospital in Calcutta and the honorary director of Wisdom Hospital. He's also received several awards both on international and national scientific platforms for his highest oration award being the Dr. B.M. Ambadi Oration and the Dr. P.N. Bale Oration Award. Sir has been a very renowned personality in establishing several important terminologies and as well as several important conference proposals, such as to name a few, such as the Dermazone, Dermacon, and the QTCon, has been recognized and accepted as the official names. And he has also conceptualized the IADVL Academy of Dermatology, and which has now become the academic lifeline of Indian dermatologists, and the ACSI Academy of Dermatosurgery. Sir has also coined the term topical steroid dependence or damage phase, and he's also the founder and the chairperson of the countrywide IADVL task force against the topical steroid abuse. And he has also received several awards, to name the few: the International League of Dermatology Society prestigious certification of appreciation, and he has also been honored for an outstanding leadership for special recognition from the Rutgers State University of New Jersey and New Jersey Medical School, chapter of Sigma Z, the Scientific Research Society. Sir has also a triple fellowship degree from Glasgow, Edinburgh, and London, and he is also a recipient of the American Association of Dermatology member Making a Difference Award for the year 2018 as well. And currently, Sir is also the Vice President of the International Society of Dermatology and also was the past President of the Association of Cutaneous Surgeons of India. And he has authored close to 5 books, 23 chapters, and 108 articles. Sir, it's a privilege to have you with us, sir. Over to you. Thank you.
Thank you, Dr. Pradyumna. It's a really privilege and honor for me to be here. And I know there's some very erudite academicians who are there in this platform before me. And thank you for giving me this opportunity. So, with your help, I'll share my screen.
Sure, sir. Thank you. Thank you, sir.
I think it's visible, right?
Yes, sir.
It
It's
is
visible.
visible.
Yes, sir.
Yeah. So the topic today is a little different from what you had in your last master classes. Is cyclosporine underutilized in immunodermatological conditions? So today, for the next 1 hour, I'll elaborate as a person who's practicing for last 25 years, but interestingly, for the last 15 or 20 years, I have not used this molecule. And then I realized the potential, and today I'm here to share my experience and what I have gathered from different publications with you all so that it can be used more effectively and more judiciously, and because it should not be underutilized. That is my opinion. To start the ball rolling, the cyclosporine A is actually a neutral cyclic peptide composed of 11 amino acids. It was first discovered and isolated from the soil fungus Tolicocladium inflatum gams. It was also known as Beauveria nivea by Borel in 1970 in Basel, Switzerland, from the soil obtained from Norway and US. Actually, this is a question for our many quizzes. The organism also known as to produce cyclosporium include Tolypocladium inflatum, Fusarium solani, Neocompus verinfacta, Cordyceps militaris, Cordyceps subsellus, and Aspergillus terris. So from these, the cyclosporum actually develops. To go back to the history of cyclosporine, uh, from 1970, J. Borel, I have shown in the photo, discovered from soil fungus, that is the Tolycopocladium inflatum gams, And in 1976, the immunosuppressive properties were actually identified. And the first organ transplant is successful using cyclosporine in 1978. In 1979, anti-psoriatic property were fortuitously discovered while treating a patient with psoriatic arthritis. And 1996 first international conference confirmed the efficacy of this new molecule, that is cyclosporine. Cyclosporine was approved by FDA and for rheumatoid arthritis and psoriasis in 1997. International Consensus Conference on Cyclosporine formulated the guideline and its use just 16 years back, that is in 2004. So these are the fungi I have told you already. A little tongue twister like a Tolipocladium inflatum. This is a scanning electron microscope. There's a beetle larva infested with a sexual stage, that is the cordyceps subcellis of the fungus that produces cyclosporine. And this is the Cordyceps militaris and caterpillar fungus or orange club. So Cordyceps subcellis is an extremely rare fungus that is the sexual state of Tolipocladium inflatum. Is it underutilized? So that is the basis of today's lecture. Let us see. Actually, FDA approved conditions are these, like a prophylaxis of organ rejection, that was in 1978 in kidney, liver, and heart allogenic transplant, severe active rheumatoid arthritis in 1997, and also in recalcitrant plaque psoriasis 2004 onwards, who have failed to respond to at least one systemic therapy. And USA approved it hovers around psoriasis. So the psoriasis, severe psoriasis, recalcitrant, treatment-resistant psoriasis, disabling psoriasis, approved in other countries psoriasis and atopic dermatitis. But there are some other indications for which we have evidence. We are generating evidence, we're gathering evidence based on publication. Not only psoriasis, it can be used in atopic dermatitis, chronic urticaria, pyoderma gangrenosum, SLE, PRP, prurigo nodularis, Behçet's, alopecia areata, lichen planus, dermatomyositis, Hailey-Hailey disease, dyshidrotic dermatitis, vitiligo, scleroderma, Sézary syndrome, mycosis fungoides, pemphigus, pemphigoid, EB acquisita, hidradenitis suppurativa, sarcoidosis. So that almost touched the entire dermatology, almost a disease from all the chapters. So this is how important this molecule can be. This is a game-changing molecule, I would say. In what dermatological indications cyclosporin can be prescribed? We have case control studies on psoriasis, atopic dermatitis, and erosive mucosal lichen planus. But we have some convincing evidence, maybe anecdotal, but we have evidence that can be used in chronic idiopathic urticaria and solar urticaria, in acute cutaneous lichen planus, in impetigo herpetiformis, in contact dermatitis, in autoimmune pemphigus, in bullous pemphigoid, Hailey-Hailey disease, Lille syndrome, Behçet's, SLE, DLE, pyoderma gangrenosum. Dosing regimen of cyclosporine in various dermatological conditions, as you know, it can be used in psoriasis, definitely. So duration of therapy from it can be used for 12 to 16 weeks, 12 months maximum. We have evidence. So response is excellent. So time to relapse and after discontinuation is about more than 90 days. I mean, about 111 days. However, 30% has no relapse after 6 months of cyclosporine discontinued. So I have seen more than 6 months of discontinuation. Unfortunately, they're doing excellent who are really suffering a lot before using cyclosporine. Intermittent short-term therapy to up to 16 weeks, rescue therapy 5 milligram per kg, little on the higher side for 12 to 16 weeks for flaring of syndrome disease. So long-term therapy below 5 per kg per day for up to 1 year, reducing dose to lowest effective. That is the sweetness. That is, you need to reach the lowest effective dose of cyclosporine and stay there. So if you can hit that sweet spot, you will win with cyclosporine. And corticosteroid, antolin, vitamin D analog, that's a wonderful combination with cyclosporine, even methotrexate, and mycophenolate mofetil in several cases. Rotational therapy, it can minimize the cyclosporine A toxicity. So to continue the dosage and regimen, so stopping cyclosporine A, It should be gradually tapered, just like psoriasis, as rebound is possible with sudden discontinuation. It can be used continuously for 1 year. There will be many repetition in all the slide because what I understand today, the our my viewers, some are using cyclosporine, some are yet to start to using cyclosporine, and very tentatively we are using. And believe me, I was in that group just 5 or 7 years back. So now I'm using this with confidence, and you, all of you, should use it with confidence. Worldwide consensus guideline up to 2 years it can be used, so that is important. Recommended in short-term use of cyclosporine for 3 to 6 months, ideally, especially for psoriasis. Intermittent short-term rescue therapy. I'll come into details of all this. So this to continue with the in various dermatological conditions, psoriatic arthritis, same 3 to 4 milligram, 6 to 12 months, and atopic dermatitis, another huge area where it can be used with excellent response. 2.5 to 3 milligram per kg per day, maximum 5 milligram. You should never go above 5 milligram. Pyoderma gangrenosum, a little on the higher side for 5 milligram, all with excellent result. Dyshidrotic eczema, Behçet's, chronic idiopathic urticaria, all between this 2.5, 3, or 4 per kg of body weight. It has also changed the treatment of chronic idiopathic urticaria where it is really recalcitrant. It's not working. You can use cyclosporine. Severe alopecia areata, little on the higher side, but if it starts the hair growth and 76% maintained hair growth for 12 months follow up. So that is very important. Otherwise, we had only steroid for with all the systemic side effects. So eosinophilic pustular folliculitis, hidradenitis suppurativa, you name it and you have it. In any dermatological disorder, many with inflammation, it can be used. Scleroderma as well. PRP, the result is mixed. Not always. I would not use PRP in the first line of choice, but definitely used in erythrodermic, classic adult erythrodermic juvenile PRP. It has been used with some success. Dermatomyositis, I have used with very good result and very low dosage are also effective. And all my patients have dermatomyositis who are on steroid now getting gradually shifted to cyclosporine and pemphigus vulgaris as well. But again, there are other treatments available for pemphigus vulgaris. And lichen planus, I have used it with confidence, and the result is excellent, good. And epidermolysis bullosa acquisita, we have some other treatment available, but you can use 4 to 5 milligram. And photodermatosis, polymorphic light eruption, solar urticaria, there also we have some reports on it. But is it all very rosy? Not really. You need to be very alert. You need to be knowledgeable about this molecule. Absolute contraindication and impaired renal function you should not use. Insufficient controlled blood pressure should not use. But when you are not sure whether a patient is actually listening to you, you are following you, and measuring the blood pressure, even in a child, should not prescribe. Severe infectious disease, avoid cyclosporine. Malignancy, no, no. PUVA therapy with cyclosporine, not recommended. Relatively contraindicated in previous potential carcinogenic therapies, significant hepatic disease, hyperuricemia. You know that the patient has hyperkalemia, simultaneous nephrotoxic drugs. You should collaborate with your colleagues from other disciplines before prescribing cyclosporine. If there is an absolute indication or necessity and there is no other drug that can help, you can prescribe, but there is relative contraindication. It is not a cytotoxic drug. So it interferes with protein or nucleic acid synthesis, which leads to cell death. I'll come to the mechanism of action in details. There's no bone marrow depression, and it's not teratogenic at all. Pregnancy category C, but it's not teratogenic per se. And it can be given, the test is bitter, so it can be given with orange and apple juice in babies and excreted in human milk, so avoid breastfeeding. It metabolized in cytochrome P450. I'll show you the photo. Of hepatic insufficiency may prolong the half life. So renal failure dialysis do not significantly alter the drug clearance, but you should be very cautious when using in a renal failure patient. So this is the mechanism of action. And must say, as a clinician myself, this is not my forte. But what I understand, you need to know why this anti-inflammatory action is happening. So cyclosporine forms a complex with cyclophilin. You can see the cyclosporine with the cyclophilin, and it inactivates the calcineurin phosphorylase. You can see that, and preventing the phosphorylation of the nucleofactor activated T cell, that is NFAT cells. So these phosphorylation is actually been avoided, prevented by this cyclosporine and cyclophilin complex. And that IL-2 is required for full activation of T cell pathway. You know that. This is the interleukin 2 gene. So when it inhibits this histamine release from mast cells and downregulates various cellular adhesion molecules, leading to the prominent anti-inflammatory activity. So it must hit there, otherwise it will not work. So inhibits the production of interleukin B by inhibiting calcineurin, inhibit the interferon gamma production of T lymphocyte, and inhibits the cytokines. We know about the cytokine storm these days. We know about the interleukin 6, IL-1, TNF alpha, IL-3, 5, 6. It inhibits everything. And it inhibits the function of antigen presenting cell, that is the APC. So, and it inhibits the function of mast cells. So, cyclosporine A also blocks the activation of JNK and P38 signaling pathway triggered by antigen recognition, making cyclosporine A highly specific inhibitor of T cell activation. What are the common adverse effects? We need to be very aware about this because the patient will call you, doctor, I have tremor. So it's nothing to do with cyclosporine. Yes, it may be due to cyclosporine itself. Headache, gingival hyperplasia. I have some wonderful photos. I'll share that with you. Hypertrichosis, hyperlipidemia. Statins interact and its level can be increased with the cyclosporine. Rhabdomyolysis is a serious problem with the cyclosporine, and hypertension, calcium channel blockers, nifedipine, and isradipine is beta deuterzum and verapamil may increase cyclosporine level. So to continue with the adverse effect repeatedly, some slides will be repeated because some things needs hammering. So we need to absolutely sure what you are prescribing. Renal failure or significant renal dysfunction are extremely rare in those below 5 milligram per kg a day. Reduce or stop cyclosporin A if it is serum creatinine rises more than 30% of the patient's baseline. Serum level of cyclosporin A may not be a good correlation with efficacy and toxicity, but relevance if a drug interaction is an issue. So how to monitor this? Again, I'll come to this slide again and again. Take the full history, previous infection, TB, hepatitis B or C, history of hypertension, kidney disease, liver disease or malignancy, full medication history, which should be repeated at every subsequent visit, blood pressure monitored, and you tell the patient two separate measurements should be more than 100, below 150/90 before starting this. It's taken again at 2 weeks, 4 weeks, 6 weeks, 8 weeks. Actually, I tell my patient to take blood pressure weekly. And physical examination, any actinic damage, cutaneous malignancy, herpes simplex, viral wart has to be carefully assessed. Investigation, remember, every time you are writing this baseline, means two separate fasting measurements, and creatinine, if discrepancy of more than two, repeat again. And it is that important. Taken again at weeks 2, 4, 6, 8, monthly after that. Blood urea nitrogen, baseline and at weeks 2, 4, 6, and 8. So do not falter on this part. So remember to do complete blood count, baseline, and then monthly, potassium and magnesium, bilirubin, fasting lipid profile, uric acid, and urinalysis. So basically, monthly you are doing CBC, you are doing potassium, magnesium, you are doing the lipid profile, you are doing the liver enzymes, and also urinalysis. So this is important. You should not forget about that. And tuberculin test as baseline should be normal, and glomerular filtration rate after 1 year of continuous therapy should be assessed, Screening programs, the cervical, breast, and colon cancer guide screening as per national guideline. That is, after 1 year can do that. Vaccination, as well, pneumococcal and influenza vaccines, uh, uh, whether there is any history of that. And CBC, creatinine, these are the things you are giving every at the baseline. Check BP regularly, even in children. That is important. So suddenly it can increase the blood pressure in a mm, predisposed child. Monitoring, basically just two things: a regular BP check and serum creatinine, electrolyte, and lipid profile. Initially at week 2, after that monthly. Do not forget to check the BP and assess the creatinine and electrolyte monthly. BP, if possible, weekly. And several articles on cyclosporine to support you when you are in trouble. Review of cyclosporine immunosuppressive safety data in dermatology patient after 2 decades of use. We have around 25 years now. When we were students, it was a new molecule. So now it has come of age. So you can see the cyclosporine. This is the our patients with really suffering from psoriasis. I'm sorry. So this is another patient of psoriasis. You can change the you can really change the quality of life of these patients with cyclosporine. So another patient with a lovely figure, uh, Dibasi. I took this picture, and I wish I could use cyclosporine. This was about 20 years back. Took this picture, and this patient is a very poor farmer, but his life is shattered with this disease. So this is the timeline of treatment of psoriasis. 1920, 100 years back, when the great uh, pandemic was going on, Geckerman regime started. The topical steroid, UVB, the phototherapy somewhere in 1970s, methotrexate, retinoids, and then the topical vitamin D. When we were students, we started this cyclosporine in 1990. I still remember Sandimune when I first started using it. TNF inhibitors, and then IL-2, IL-23 inhibitor, then PD4 inhibitor, IL-17 inhibitors, and it is going on and on. So the upshot of psoriasis treatment when the patient comes to your clinic, it is methotrexate, retinoid, cyclosporine, apremilast, and biologics. So our therapy revolves about this, other than the phototherapy, definitely. I'll not touch the biologics, the adalimumab and etanercept today. I'll limit our discussion on cyclosporine today. So that brings to the first question. Dr. Pradyumna, if you are ready with the first question, you can send this to
Yes, sir.
our. Uh,
Yes, sir. So they will be virtually projecting it, sir. So Jay, can you please help with that? So, team, we will be having our first polling question now,
so, which is
and
your preferred systemic agent in moderate to severe psoriasis patient with rare condition? Is it methotrexate? Is it acitretin? Is it cyclosporine or apremilast? So this is, you need to respond. If it is A, methotrexate, B, acitretin, C for cyclosporine, and D for apremilast.
yes, Jay, can we have the answer, please?
Yeah, I need the answers.
Yes, sir.
So this is what is the preferred systemic agent. So there are four choices: methotrexate, acitretin, cyclosporine, and apremilast. So I can't vote. So
Yes.
my voting power is stopped. Let's see.
Yes.
Oh, cyclosporine is winning with a hopping 68 percent. It's just almost like U.S. election. The Reds have it, the Blues lacking nothing like methotrexate is coming as a second 24%, acetretin 5%, apremilast about 3%. Thank you very much. And so we'll again move. I'll come to the question again in between my discussion. So types of psoriasis and how I diagnose this is a basics slide, as dermatologists all know about different parts or different aspects of psoriasis. And psoriasis treatment with respect to effectiveness and toxicity, basically they call corticosteroid, calcipotriol, anthraline, colta, or phototherapy with PUBA, UVB, and systemic biologics, cyclosporine, methotrexate, or retinoid. So these are three major form of therapy. You know, the topical, phototherapy, and systemic. And treatment are based on psoriasis severity and time of presentation. You all know that. So for mild psoriasis, usually it's treated with topical therapy, progressing to phototherapy in case of insufficient response, and moderate to severe psoriasis that requires systemic therapy, and cyclosporine comes there. So challenges in treatment of cyclosporine psoriasis patients. So this is an original investigation. Under treatment trends, and treatment dissatisfaction among patients with psoriasis and psoriatic arthritis is a finding of the National Psoriasis Foundation Service. And the conclusion is non-treatment. Can you imagine in a developed country, non-treatment and under-treatment of psoriasis, patient of psoriasis and psoriatic arthritis remains a significant problem in United States. So you can understand the plight in countries like us, the subcontinent. And while various treatment modalities are available for psoriasis and psoriatic arthritis, widespread treatment dissatisfaction exists, and effort in advocacy and education are necessary to ensure that the effective treatment are accessible to this patient population. And I guess cyclosporine was utilized in patients even in US. So this National Psoriasis Foundation, they carried out a survey between 2003 to 2011. Are my slides visible?
Yes, yes, sir, they are visible,
Okay,
sir.
okay.
There was a
Among
small time lag, it's
yeah,
visible now,
yeah,
sir.
yeah. So among 4,862 participants, 52% were dissatisfied. So can you imagine? This is a huge number. So even in India, in our patients, they are not always satisfied. Our patients' psoriasis untreated, according to National Psoriasis Foundation survey. So there are patients who never actually received any treatment for psoriasis. There's a significant proportion of respondent they have not received any treatment. And the challenges are, as per the US survey, this is US survey, systematic therapy are underused in patients, and introduction of systemic therapy may be delayed, leaving patients with uncontrolled disease. Some patients may not respond to therapy, and some do respond initially, may experience a loss of response over the time. Adherence to traditional therapy is low. So, what are the challenges do you face while treating psoriasis patients? So, that brings us to our next question. Let us say, is it loss of response to therapy online? Is it poor adherence? Is it affordability to systemic therapy, or all of the above? Let me sip some fruit juice. There's no cyclosporin in it. There's orange juice. Let's see. It's all of the above. There's absolutely agree. There's a huge number, 68% agreed that we have the loss of response to therapy over time. We have the poor adherence. We have the affordability for systemic therapy. Actually, everything are all the challenges for psoriasis. Thank you very much, team. So cyclosporine were in psoriasis treatment. is a monotherapy in moderate to severe psoriasis, pustular and erythrodermic psoriasis, flare, and combination or sequential therapy. So the use of cyclosporine psoriasis, a clinical, there are innumerable number of articles in last couple of decades. Actually, in last 15 years, to tell you the truth, this was published in the British Journal of Dermatology, one of the earliest paper in 2004, when the our thinking pattern started changing around cyclosporine in psoriasis. An excellent article. And psoriasis 3 to 5 milligram per kg per day consider the ideal body weight. Remember every time this is the dose. So step up versus step down approach. I'll come to that later on based on the different authority recommendation. Taper to by 0.5 to 1 milligram per kg per day, even every 4 weeks. Chronic versus intermittent use. Cyclosporine versus methotrexate. Cyclosporine act very fast, but methotrexate takes 4 to 6 weeks to kick in. So cyclosporine and psoriasis, this was in 2008 National Psoriasis Foundation Consensus Conference. And it also, the conclusion was it is safe and effective for the treatment of psoriasis. So it has a particular useful role in management of psoriatic crisis, treating psoriasis unresponsiveness to other modulators, bridging the other therapies, and treating psoriasis within a rotational scheme or other medication. Appropriate patient selection and monitoring will significantly decrease the risk of side effects. So that was an historic article in JAD. This is again New England Journal of Medicine 2003. This is around the time when cyclosporine was actually recognized and established its role in severe psoriasis. Methotrexate versus cyclosporine in moderate to severe. The conclusion is no significant difference, that it's very effective and it's safe. Uh, Again, this is JADV. This was published in JADV in 2005, about 15 years back, in childhood psoriasis. So one of the earliest article to deal with childhood psoriasis and cyclosporine. So what they told is improvement of skin lesion were achieved after between 4 to 30, that is mean 12 weeks of treatment. Within 3 months, it started kicking in with complete remission in 3 children. So that is quite a statement. And relapse of lesion occurred in other children during cyclosporine A reduction, but they respond to a dose increase. The treatment was found to be well tolerated without any significant side effects. So that's a big relief to the world because we have very limited thing for childhood psoriasis. So atopic dermatitis, that is another huge topic for our children. Stepwise management, we know about that. The basic things, only the dry skin, uh, skin hydration, emollient avoidance of irritants, identification of the addressing specific trigger factors. If it is a mild to moderate AD, that is the step two. Mild, mid, low, mid potency TCS. Once you start with TCS, there is no end to it. TCI is much better than that. Mid potency TCS or TCI and severe recalcitrant one, you may go for cyclosporine A or UV therapy. So cyclosporine A helps there as well. Atopic dermatitis and cyclosporine, small number of patients and extreme end with poor quality of life. Response is dose related. Toxicity is not an issue. Higher doses, short courses can be extended depending on response. There is RCT, 15 studies, 602 patients, solid base on that, double blind control. It's on Lancet, crossover study of cyclosporine in adults with severe refractory atopic dermatitis. Another one in JADV. So that was 2007, cyclosporine in the treatment of patient with atopic eczema. A systematic review and meta-analysis, they concluded that due to the evidence of publication bias, the quantitative result need to be interpreted with caution. So effectiveness of cyclosporine is similar in adult and children, that is important, but tolerability might be better in children. So in case of your pediatric population, you may use cyclosporine with confidence, more tolerable as data to inadequately adequate evaluate long-term effectiveness and safety of cyclosporine in patients with atopic eczema are unavailable. That was 2007. Long-term register are encouraged. So now we are having this. So journal scan, we are having 12 different interventions for moderate to severe AD have been studied. 34 RCT, gaining evidence, piles of tons of evidence now. Strong recommendation are not only possible for short-term use of cyclosporine. Methodological limitation, the majority of the trial prevent evidence-based conclusion. So many other articles on cyclosporine, and this is another. Dose is 2.5 milligram per kg. Duration is 12 to 16 weeks. So the change, you can see the pre-treatment and post-treatment. Cyclosporin treatment of atopic dermatitis really associated with systemic disease? Not really. And 5 milligram per kg per day and reduced by 1 milligram every 3 to 4 weeks. That is how you use in atopic dermatitis. May use simultaneously oral steroid for initial 4 to 6 weeks if we are that courageous and very enthusiastic about it. But usually cyclosporin alone can help in that cases. Systematic review of severe atopic dermatitis is a systematic review, and so that was in active dermatol venediol in 2004. So 11 studies consistently showed the effectiveness of cyclosporin. Cyclosporin is recommended as the first option for patient with atopic eczema refractory to conventional therapy. The efficacy and safety of long-term oral cyclosporine. So more evidence are being gathered for the safety, efficacy, all convinced safety of cyclosporine. Cyclosporine, the treatment of severe atopic dermatitis, is a retrospective study, and it says that the effect is not long-lasting and relapses occur, but actually, it is if it is followed up for long enough. Cyclosporine is very useful in patients with severe recalcitrant atopic dermatitis who have failed to other therapies. This is another disease, and we can all diagnose this as lichen planus. Before the use of cyclosporine, we were using topical and systemic corticosteroids, and with all the side effects. Now you have this. This is published in JAD by our Aditya Gupta was one of the authors of this treatment of severe lichen planus with cyclosporine, and they show good result. Very effective. 3 milligram per kg per day and reduce every third week. It is far better than oral steroid. So that is a sweeping statement. Another disease, urticaria. So management of chronic urticaria, avoidance, these are the steps. Avoidance of triggers, monotherapy with the second generation antihistamine, you all do that. And step two is dose adjustment of second generation used in step one. Add another second generation antihistaminic. And we have so many webinars on this, what to add and what is the ideal combination, blah, blah, blah. Dose three is, step three is dose adjustment with potent antihistaminic like hydroxyzine or doxepin. If the doxepin is tolerated, then it's fine. And after that, when nothing helps, stage four, that is anti-inflammatory agents and immunosuppressant or biologics. Cyclosporine A actually can help. It on helper T cell to inhibit T cell receptor activate induction. You remember that I have shown how it acts. Cyclosporine may also inhibit the IgE stimulated muscle degranulation and stimulate the TGF beta expression. So low dose cyclosporine in the treatment of severe chronic idiopathic urticaria. So that was also published in 2007, and 2 to 3 milligram per kg was shown to be beneficial. And AST positivity could not predict a response to treatment. In some cases, prolonged treatment for 1 to 2 years is needed. So that means it is 1 to 2 years you can use that. So it is as safe the use for 1 year or even 2 years in some European studies. Cyclosporine treatment in patients with concurrent autoimmune urticaria, autoimmune hepatitis. Cyclosporine A is useful in chronic idiopathic urticaria where antihistamines fail. That is the headline of this particular article. And yes, you can use in Steven-Johnson syndrome in toxic epidermal necrolysis. We all know that if it is below 10% body surface area, SJS overlap is about SJS 10 to 30%. Over 30% of body surface area involvement, it is 10. So we know the drugs commonly used. Mainly we get anticonvulsant, rarely sulfonamides are used these days, some antibiotics, NSAID, allopurinol, and nevirapine. And mechanism of action of cyclosporine in 10, if we again go back to that slide, it inhibits the IL-2 inhibition of CD8 activation. So it potent anti-apoptotic effect through inhibition of NFKB, FASL, CD95L, and TNF alpha. It inhibits the drug-induced expression of CD95R FAS receptor and CD95L, that is fast ligand messenger RNA. So tissue sample analysis, the Packaway et al., they performed the tissue sample analysis of two patients with 10 treated with cyclosporine 5 milligram per kg daily for 5 days versus two patients who got IVIG 0.75 gram per kg daily for 5 days. Marked reduction of CD94 95R, that is the first receptors clinically involved in non-lesional scale in patient getting cyclosporine in these patients and of 10. And IPIG non-lesional skin showed moderate increase of 95 CD95R. These findings support a mechanism of action of cyclosporine A in the treatment of 10, protected the progression of SJS to 10 by downgrading the apoptotic pathway in non-lesional skin. So that is a huge, huge development. An open trial of cyclosporine in SJS and toxic epidermal necrolysis. This published in BJD, and just 10 years back, the final diagnosis is just 10 and 10. So we have three category of patients, 10, 12, and 7. 1 month treatment completed in 26. Cyclosporine was stopped after more than 10 days in three cases of neutropenia. For neutropenia, remember, you need to do the CBC. So if there's neutropenia, definitely you need to stop that. Cyclosporine dosage was tapered earlier than scheduled in two cases for alteration in renal function. The prognostic score predicted 2.75 death, non-occurred, and the conclusions, both the death rate and the progression of detachment seemed lower than expected, suggesting a possible usefulness of cyclosporine in SJS and 10 that needs to be confirmed. So these are wonderful areas where this molecule is showing its effectivity. So this was also published in our journal by Manas and Rajesh Verma and Dr. Jika Singh, cyclosporine in SJS, and toxic epidermal necrolysis and retrospective comparison with systemic corticosteroids. So they concluded that definitely suggests cyclosporine was encouraging a role in the management of uncomplicated SJS, SJS 10, and overlap of 10. What are the adverse effects? I have told, again, I'm coming to that. Headache, hypertension, hyperglycemia, renal dysfunction, hirsutism, hypertrichosis. Remember, this can happen in children also. Paresthesia, hyperesthesia, influenza-like syndrome. These days, patient will get very paranoid and will call you. Tell them it may be due to cyclosporine. Diarrhea, abdominal discomfort, lethargy. I have not seen that. And patients are very energetic after taking cyclosporine because their symptoms are getting diminished and the patients are happy always. And musculoskeletal or joint pain. So monitoring the patient on cyclosporine, I have told you before, but again, I'm coming back to the slides because you need to ingrain in our gray cell because every day we need to learn from our experience. A complete physical examination, testing for tuberculosis, blood pressure measurement. Do not forget that presence of any occult infection, baseline laboratory test on two occasions, serum creatinine, BUN, CBC, magnesium, potassium, uric acid. Continuous monitoring what I do, the blood pressure weekly, and definitely 2 weeks initially and then monthly, serum creatinine, blood urea nitrogen, uh, all the serum lipid, potassium, magnesium, uric acid, and CBC. So this is how it happens, the adverse effects are dose and duration dependent and typically reversible. Tell that this is reversible. Even these changes in the gum are reversible with appropriate intervention. So serum creatinine monitoring. Serum creatinine increases 30% above baseline. Repeat measurement in 2 weeks. Reduce to less than 30% above baseline, continues. If it remains more than 30% above baseline, stops cyclosporine. Resume it, it returns within 10% of the baseline value. But better to avoid cyclosporine if it shows that a change towards on the higher side. Blood pressure monitoring, there is a guideline. Blood pressure at the baseline more than 140/90, repeat measurement 2 weeks later if hypertension persists. Do not prescribe cyclosporine on that day one. Treat with antihypertensive therapy, preferably dry hydropyridine calcium channel blockers, that is amlodipine or isradipine, or reduce cyclosporine dose by 25 to 50%. Now, very interesting part of this lecture is the evidence-based guideline for use of cyclosporine in psoriasis management. Do we have some guidelines? I'll just discuss the brief outline of this to establish a versatile drug in the management of psoriasis. I'll discuss the BAD, the AAD, the European S3, and the Canadian guideline. So, and it will be based on this induction therapy, intermittent short-term therapy, combination therapy, rotational therapy, rescue therapy, weekend therapy, maintenance therapy. So let us first start with the BAD, that is British Association of Dermatologists. And this is the 100th year of BAD. Unfortunately, everything is topsy-turvy. In psoriasis vulgaris and severe psoriasis patient for rapid control, induction therapy. Remember, these are the established terminology. What is induction therapy? Standard regime comprises of initial dose for inducing remission of 2.5 to 5 milligram per kg per day, given orally in a single dose or two divided doses. The higher initial dosage of 5 milligram per kg per day can be given when rapid control is required. If you have a large heart, if you're courageous enough, go ahead for a short time. When time is less critical, lower dose may be used initially and increase if the psoriasis is not clearly improving after 1 month. In severe psoriasis, to so intermittent short courses can be used just like steroid. An alternative, weekend therapy, continuous therapy with a review of the reducing cumulative exposure. So if you're not sure that your cyclosporine is having some negative effect on this patient or it is really having some good effect, because you do not want to stop cyclosporine completely, go for intermittent therapy. Step down dosing regimen. If it is severe psoriasis to achieve PASI 75 in short time. A 12-week study of cyclosporine in 61 patients with severe psoriasis, 5 milligram per kg per day starting dose, and a decreasing step-down regimen is used. The percentage of patient achieving PASI 75 response at 12 weeks are higher in the step-down regimen group. And the mean time to achieve PASI group. Start with high dose, step down. Combination therapy, topical agent. So that is also a wonderful thing. In a study clearing up 90%, if you combine the cyclosporine with am I visible? Yeah, I think everything is fine.
Yes, sir. Visible, sir.
Yeah, yeah,
Yes.
yeah. And the very low dose of 2 milligram per kg per day by combining cyclosporine with calcipotriol. So clobetasol propionate accelerates the response of cyclosporine. 80% reduction in PASI was achieved in 6 weeks using cyclosporine alone, and in 3 to 5 weeks using combined regime. So 6 weeks to 3 weeks, the combination therapy actually can change the like uh, the game completely. AAD guidelines, let us see how it differs, how it actually agrees to the BAD guideline. And that was actually in 2010, JAD, it published this in erythroderma or suberythrodermic or pustular psoriasis, rescue therapy. It is actually an aggressive one. The short course of cyclosporine is a severe flares of disease. It's a rapid onset of action, and an alternative maintenance therapy is instituted. 33%, 30 patient with erythrodermic psoriasis started at 4.2 milligram per kg per day, then gradually decreased to remission by zero point 0.5 milligram per kg per day every 2 months. 67% achieved complete remission. So that is wonderful. It started with a 4.2 on the higher side and complete remission in 67%, two-thirds of the patient, and 27% achieved significant improvement in 2 to 4 months. So this is a game changer actually. And in severe psoriasis, patient with this reduced cyclosporine and cumulative exposure, intermittent short-term therapy. So just like the BAD guideline, the intermittent short-term therapy, 12 or 6 weeks is the most frequently recommended agent. You use for some time and then cyclosporine off. Again start, again reassess. If everything is okay, again you can start. Again you can withdraw the treatment. So this is how it goes. And rotational therapy. And AAD guidelines suggest that intermittent therapy is preferable to long-term therapy. That and treatment regime be tailored to the individual need. Actually, medicine is an art of a practice in science. We all know that. So rebound flare, so it should be tailored based on the individual need of the patient. A rebound flare of abrupt withdrawal of treatment, that is 125% of the baseline PASI, has not been observed in studies of cyclosporine treatment. So I have not seen in cyclosporine rebound flaring up after stopping that. We have not seen. Combination therapy can be combined with topical therapy such as corticosteroid or vitamin D3 analog and improved response. So based on that, our next question is, do you believe combination therapy of cyclosporine with topical calcipotriol will help reduce drug toxicity and better clinical result in psoriasis? I'll again tip the orange juice. Yes, no, maybe, never try it. I use both of them and results are good. Read carefully, answer. Oh, so you believe that combination therapy cyclosporine will definitely help in reducing the drug toxicity. Thank you very much. And never tried actually about 31%. And so that is also interesting. So we have about one third who have never used this, and but I'm very happy with the positive result with 58% who has actually believed that combination therapy, cyclosporine and topical calcipotriol will help. Definitely. Thank you very much. You are listening to this lecture carefully. And then there is evidence-based guidelines for use of cyclosporine based on the European S3 guideline. So they also, these are basically same. The cyclosporiasis vulgaris and severe psoriasis patient with rapid control, the induction therapy, same with the American guideline. And the patient not respond satisfactorily to initial therapy after 4 to 6 weeks with the lower dose 2.5, it can be increased to 5 milligram. Actually, they start with a little lower dose, the American guideline. Then they go a little up. Higher dose results in faster and more complete clinical response. And maintenance therapy and a 9 to 12 month study, lower relapse rate, initial dose 3 to 5, and after remission, every 2 weeks decreased to a maintenance dose of very little, zero point 0.5 to 3. And mostly it is around 2, it is maintained. So 2 milligram per kg per body weight. So in a person of 50 kilo, so 100 milligram of cyclosporine is enough to maintain the balance, maintain the maintenance. So in severe plaque psoriasis, to achieve passive response quickly, short-term therapy and intermittent therapy. Short-term, cyclosporine uses a short-term therapy for 2 to 4 months, and course of treatment can be repeated in intervals. The same thing, the what was discussed in the AAD guideline. The initial dose is generally 2.3 to 5 to 3, the basic average dose. Intermittent therapy, over 8 to 16 weeks, and with the dose reduction at the end of induction therapy, zero point 0.5 per kg every 14 days is recommended. And cyclosporine can be drawn when significant improvement is achieved. And we have the Canadian guideline as well. That was older than these guidelines in 1999. So evidence-based guideline for the use of cyclosporine in psoriasis before FDA approved it. So in psoriasis vulgaris with severe psoriasis patient for rapid control, short-term induction therapy. Cyclosporine is indicated for short-term induction therapy for flare, moderate to severe patient. Oral dosing regime between 2.5 and 5, and subdivided into two doses recommended for 12 weeks. This is actually what we do. And intermittent therapy and short courses, intermittent short courses can be used as an alternative to continuous therapy with a view of reducing the cumulative exposure. Basically the same thing what we told. Combination with calcipotriol. They also see the importance of calcipotriol and angual hyperkeratosis, onycholysis, pitting improved in approximately 80% of the patient using cyclosporine plus calcipotriol. Combination therapy, low dose cyclosporine 2 milligram with calcipotriol and betamethasone improved the clinical response at week 8 or 87% achieving PASI 75. So that brings us to our next question. Do you consider cyclosporin weekend therapy? Very interesting. 5 milligram per kg per body weight, Saturday, Sunday, and along with other treatment options to put cyclosporin patient, psoriatic patient in remission. Your response can be, I was not aware, hence never tried. Aware but never tried. Good concept. I'd like to try on my patient. May not be appropriate. So let us see. As I can't vote, I'll sip the orange juice again. Oh, so it is a good concept and would like to use in my patients. So 72%. So my viewership, they are getting more and more energetic about cyclosporin. Thank you very much. I'm touched. And but 16% was I was not aware. So and nobody thought it is not appropriate. Thank you very much. Thank you very very much. Psoriasis types, you know that it onset, it can be between 40 to 40 years. Onset can be between 40 to 75 years. And this is based on Dr. Shiva Prasad Rai Chaudhary, our Shibuda, and his article published in Pediatric Dermatology in 2000. And in these cases, these patients are horrendous patients. It is a pustular psoriasis, and you can see the result, the complete life-changing result. These photographs are taken from Dr. Sandeep Andhar and Dr. Abhi Saraswat. Thank you very much, my two dear brothers. You can see the change of these patients with cyclosporin. It completely, if you compare these with the first slide, this is how cyclosporin can actually help. And look at this for 5 years, and after 24 weeks of cyclosporine A. Actually, this lady was thinking of committing suicide. He had a suicidal ideation, and now his it's completely changed. Look at this particular boy. Smile has come back. He's a completely changed boy. So cyclosporin in childhood psoriasis, there's a number of patients, 16, doses 3 to 5 milligram. There's a good control made on 4 weeks, duration is 3 to 6 weeks. Control of psoriasis is better and long lasting in children than adults. Drug-free, disease-free period for 2 to 4 months. This is in pediatric age group. This is what you need to learn. Preparation capsules are 100 milligram, 50 milligram, 25 milligram, and solution, it is very, very strong. Remember, the solution is not exactly very weak concentration. It is 100 milligram per ml, and the 50 ml bottles are available. So you need to prepare these for your children. In cyclosporin syringe, ordinary the insulin syringe or 5 ml syringe. I'll show you how to prepare this. I learned this from Dr. Dhar Sandipandhar, several lectures. So this is how it is done, and you can see this is you can dilute that, and cyclosporin newborn baby used extensive psoriasis at birth. Very high dose was given, not given very high dose. Oral prednisolone 2 mg per kg. Baby developed Cushingoid features in 15 days. He was put on cyclosporine 5 mg per kg per day, two divided dose. Oral steroid was tapered off in 15 days. All necessary tests were done. How it is done? In insulin syringe, 1 ml is divided to 40 equal units. You can take a screenshot of this. Each unit is therefore had 0.025 ml. I told you it is so, and each unit represents 2.5 milligram of cyclosporine. So you have divided into 40 equal unit. Each unit is having 0.025 ml. So each unit means 2.5 milligram of cyclosporine. In a child of 40 milligram body weight, 40 kg body weight, if you give zero point 0.5 milligram per kg per day, so the dose required will be 20 milligram, just 20 milligram. 20 milligram capsules are not available. So this way, how we can give? So 2.5 milligram of in each unit you have this 2.5 milligram. So how many unit you will give? So 4 unit means 10 milligram. You will give 8 units in this particular case in a 40 kg body weight child after 4.5 months of cyclosporine therapy. Can you imagine this change in with any other therapeutic regime? After 2.5 months of cyclosporine A therapy, so after 2.5 months of cyclosporine therapy, this is how it completely changed our pediatric age group patient with cyclosporine. So cyclosporine adverse effect is hypertrichosis and gum hyperplasia. I have some wonderful photos on that too. And these are the hypertrichosis photos, and you can see the hypertrichosis in this particular boy, and also hypertrichosis on the shoulder, and the gum hyperplasia. And gingival hyperplasia is caused by fibrous hyperplasia to cyclosporine has a higher incidence reported in children. The pathogenesis is uncertain, but it is often associated with poor oral hygiene and plaque control and removal of oral irritant. When you are referring this to a dental surgeon, please tell that patient is on cyclosporine. So don't worry. Once I stop, and within like a few months, within 2 to 3 months, it will come down. And treatment with metronidazole resulted in a complete resolution in one season 4 patient. So this is how it may look like. Cyclosporine in pediatric population is found to have decreased sensitivity to cyclosporine, higher clearance or decreased viability of the drug. A meta-analysis of cyclosporine in atopic dermatitis suggested that although the effectiveness was similar to adults, tolerability is better in children than adults. So in the pooled analysis, 2.5% children has increase of creatinine or more than 30% per month or treatment and no child development hypertension. So that is music to our ears. There's a decreased bioavailability of cyclosporine in children, and children are less susceptible to cyclosporine-induced nephropathy than adults. So this is how the monitoring should be. Again, I'm coming back to this slide again and again, because this is what you need to remember. The lab investigations, full blood count, pre-treatment, creatinine electrolytes, liver function test, uric acid, bilirubin, lipid profile, pregnancy test, blood pressure. Everything is being done. First 3 months, every 2 weeks, you are doing the creatinine and blood pressure. And monthly, you are doing the complete blood count, liver function test, uric acid, bilirubin. Thereafter, monthly, only the CBC creatinine. Do not forget creatinine, liver function test, bilirubin. Do not forget blood pressure. Every 2 months, you can do the lipid profile. So, coming to the summary of the use of cyclosporine in dermatology, cyclosporine is licensed in the following indication. Strength of recommendation is A, atopic dermatitis in more than 16 years, and psoriasis more than 16 years in pediatric age group. Good evidence to support the use of cyclosporine outside of this product license for the following indication. Strength of recommendation is A, atopic dermatitis less than 16 years, Behçet's chronic spontaneous urticaria, graft versus host disease, palmoplantar psoriasis, pyoderma gangrenosum. Calci- Cyclosporine should only be used as a last resort and on concurrent evidence seem unlikely to be helpful to the following indications. Strength of recommendation is D in alopecia areata, DLE, in pemphigus foliaceus, and pemphigus vulgaris. You have other options for this disease. So that brings to the last question of today's discussion. Cyclosporin being a versatile drug recommended to be used as induction therapy, intermittent short-term therapy, combination therapy, rotational therapy, rescue therapy, weekend therapy, maintenance therapy, or all of the above. Let us see how my viewers respond. And I'll sip my orange juice again. Wonderful. So I was thinking that if there is 99%, I'll single out that person and ask them to use it. Thank you very much for your wonderful answer. It is really 100%. All of this above are actually recommended. So is it underutilized? Yes. Cyclosporin, due to faster action, can be used as a crisis buster in severe forms of psoriasis, ectodermic and pustular. It is there in our textbook. How many of us are using it? Cyclosporin A can be recommended in short-term rescue treatment for psoriasis and atopic dermatitis in appropriate patient. Do we know that? How many of us are using this? Cyclosporin A may be used for therapy of pyoderma gangrenosum, refractory chronic urticaria. When was it used in urticaria, cyclosporin? Cyclosporin A in low dose with CS and corticosteroid is effective in dermatomyositis. Cyclosporin A should be included in the list of systemic drugs for severe childhood psoriasis, along with methotrexate and retinoids. Intermittent short course regimen is established in clinical practice, and duration of therapy should be below 2 years and preferably 1 year. Elimination of glomerular filtration rate is advocated in patients taking cyclosporin A for more than 1 year. Remember only that. An intermittent short course regime is established in clinical practice, and duration of therapy should be below 2 years and preferably 1 year. Definitely, it is underutilized for the treatment of psoriasis entity, where it can be used judiciously, empathically, based on evidence. So I acknowledge the contribution of Dr. Sandeep Andhar and Abhi Saraswat, my two brothers, for this slide sets. Thank you very much for your time spent with me, and stay safe. Thank you very much.
Thank you, sir. Thank you very much for your very valuable session. And it has been enlightening in a lot of angles. As though so far we had a lot of scientific interaction around psoriasis, but your psoriasis touched based upon a lot of dermatological conditions. And I'm very sure it will be useful to all our attendees today as they'll be putting it into practice. So, with your permission, we will move ahead.
Yes.
Thank you, sir. So, as per the first polling question that we had, one of our viewers also wanted to understand your practical perspective with regard to the same question. As to in psoriasis, would you prefer cyclosporin, methotrexate, acitretin, or apremilast as a single agent or as any of the combination of these four?
Actually, I was heavily with methotrexate, and I'm still use methotrexate, but cyclosporine has definitely changed. And in case of patients who are on methotrexate or any other medicines and not responding, and these days we rarely get naive cases on psoriasis. It always happens that patient has doctor hopping from this to that, and now is in front of me, needs some real effective treatment. And in those cases, cyclosporine works like magic.
Thank you, sir. Thank you for your opinion on that. So the next question that's just come up is, so which is the minimum age to start cyclosporin, and how do you in practice generally taper cyclosporin after it has shown its beneficial effects?
I could not hear. Can you
Sorry,
just,
sir.
yeah.
Sorry, sir. Which is the minimum age to start cyclosporin, and how do you in practice generally taper
Yeah,
cyclosporin
yeah.
post its
Actually,
beneficial
as per
effects?
the standard recommendation, below 16 years, below 12 years, we have some international guideline, but the recommendation based on this Canadian, this British, American guidelines, now it is changing. We can use it below 12 years as well. And I have shown you it can be used in absolute in pediatric age group. And I start using, actually I'm not that aggressive using 5 milligram per kg per body weight. My idea is about 3 milligram per kg per body weight, and then I start reducing the dose and try to reach that sweet spot when it is effective. And if it is 50 milligram per day, be it. If it is 50 milligram twice daily per day, be it. So there it we need to reach that sweet spot and leave it there.
Thank you, sir. Thank you for your opinion on that. So the next question is, in case breastfeeding mothers, has there been a use of cyclosporin in your experiences?
I have not used it.
Okay, thank you, sir. Uh, do you come across any drug interaction that you have seen, sir, with cyclosporin, with combination, preferably say such as methotrexate or
Yeah,
azathioprine and so on?
actually, you need to be very careful, and you need to coordinate with your medical specialist friends regarding what are the other medical medicines they are having. And with cyclosporin, especially in case of very aged individuals where he is on other medications, be little careful about it. But otherwise, in infant, in pediatric age group, it is extremely safe to use cyclosporin.
Thank you, sir. So this is the last question that we will be taking in the interest of time. So the last question is, since in severe psoriasis flare, if methotrexate has reached its cumulative dosing, would you prefer acitretin or cyclosporin or some other drug in the management?
Any day I'll go for cyclosporine because acitretin, we know about the relative negativity of these. You need to be very careful about the lipid profile. I have some bad experience with that, but for cyclosporine, I can use it with confidence.
Thank you, sir. I think that brings us to the end of the session. So just before I hand over the vote of thanks to Mr. Surajit Mitra, I would like to have a few closing remarks from your side.
Uh, Thank you for giving
Uh,
me this opportunity, and it was wonderful to share my views. And I always tell, just 5 years or 7 years before, I was on the other side of the table. I was very reluctant to use. I knew everything, all the evidences were there. I read all this. Once I started use, I gathered confidence, and I'd request you too to start this using with confidence.
Thank you, sir. Thank you for that. A very positive note from your side as well, sir. And I would like to hand over the session to Mr. Surajit Mitra, our regional business manager. Kindly propose the vote of thanks. Thank you.
uh, Thank you so much, sir. I take this opportunity to thank you, Dr. Dahiri, for today's talk, which has been so rich in its scientific content and backed, as always, backed by your so rich clinical experience. Believe in me, sir, it was very enriching. I am sure that has been very enriching to everybody, all attendees today, and it brought a conviction level too high. I also additionally thank all the participants today for their unwavering attention throughout the presentation. And Dr. Lahiri, we look forward for such valued scientific programs, platforms from your end in near future too. We are deeply honored, Doctor. Really, really, it increased the conviction of each and everybody, widened the scope of cyclosporine. Thankful.
Thank you very much.
Thank you so much, Doctor. Thanks, everybody.
Thank you all. Thank you all for your valuable time. We wish you all stay safe and stay healthy, and wish you too, Doctor, as you're in the front line. So thank you all, and we wish to see you all in our future engagements as well.
Yes,
Thank you all.
definitely, sir.
Thank you.
Have a nice weekend,
Good day
everybody.
to you all.
Thank you.
Good day to you all. Thank you.
Thank you very much, all.